Merhaba herkese. Şenol Bey bugünkü sunumumuzu yapacak. Medical Applications of Computational and Experimental Mechanics başlıklı bir sunumu olacak. Şenol Bey'den kısaca kendisinden bahsetmesini rica edeceğiz. Seminer için şimdiden çok teşekkür ederiz.
Ben teşekkür ederim hocam. Ben İTÜ Makina mezunuyum. Lisansım buradan. Ondan sonra İTÜ'de doktora yaptım ya bilişim enstitüsünde. Hesaplamalı bilimler mühendislik programında. Orada doktora tezim kardiyovasküler mekaniks'ti yine. Daha çok ama modelleme, adult kardiyovasküler sistem modellemesi üzerineydi. Oradan sonra biraz Koç Üniversitesi'ne geçtim. Postdoc yaptım bir süre. Carnegie Mellon'la birleşik bir postdoc'tu. Yani supervisor'ım benim Carnegie Mellon'daydı. Oraya gidip geliyorduk. En sonda şu an University of Texas'tayım. Makina bölümünde postdoc yapıyorum. Biyomedikal bölümünde aynı üniversitenin öğretim görevlisiyim. Yılbaşı tatili olduğu için de şimdi Türkiye'deyim. Bu fırsattan istifade bir seminer vermek istedim burada. Geldiğiniz için de teşekkür ediyorum herkese. Bir süre sınırı var mı acaba sonunda ne kadar veya?
Genelde bir saatte soru cevap vermek.
Tamam. Tamam, teşekkürler. Şimdi bir çok slide var aslında ama hepsinde çok fazla üzerinde duramayabilirim. Eğer sorunuz olursa hemen sorarsanız daha iyi olabilir çünkü bir sürü topik var alt alta. Yani geri dönmek biraz zor olabilir, unutulabilir. O yüzden hani görüldüğü anda sorulmasını tavsiye ediyorum. Bugünkü konu aslında benim geçen yıl yayınladığım çalışmalar. Kısa kısa. Bir de şu an üzerine çalışmasını yaptığım konular. Onlarda kısa kısa bahsedeceğim. Genel olarak bütün konular aslında en genel halde kardiyovasküler mekaniks konusu başlığı altında toplanabilir. Alt konular olarak bakarsak surgical planning, sunum İngilizce ama İngilizce'de devam edebilirim veya okay. The outline of the talk can be listed as surgical planning, biofluid dynamics, tissue mechanics, diagnosis, prognosis, and treatment planning, drug delivery, and high-performance computing. First of all, surgical planning. Nowadays, it's really a hot topic, surgical planning. In medical centers, get help from engineers or universities, engineering departments. The reason for this is mostly the surgery performances are lower than expected. For example, especially for pediatric patients, when you do a surgery and after the surgery check the performance of the surgery, for example, the perfusion of the lungs is lower than expected, or perfusion, cerebral arteries, brain perfusion is lower than expected. So, what is the result? Mostly they repeat the surgery. For especially pediatric patients, these surgeries are repeated. And of course, this is not something wanted, both for the medical centers or for the patients. And our solution to this is doing the modeling, all possible scenarios for the surgery, doing the modeling beforehand on computer, or sometimes experimentally, and check the outcome of the possible scenarios, all scenarios. For example, there are 10 scenarios for a specific surgery. We model 10 of them and try to predict the outcome, and then share the data with the surgeons. And then they decide, based on our simulations, the best possible scenario for the specific patient. These are patient-specific studies mostly. For example, this is a cardiopulmonary bypass surgery, and this is an aortic arch. This one is aortic arch. And if you see, this is a very narrow, right? This is ascending aorta, and this should be larger than this descending aorta. But this is actually congenital disease, comes with the birth. And these surgeries are performed within, for example, 1 month of after the birth. So these patients are sometimes 2 weeks old. And for example, since this ascending aorta will be repaired, they need to stop the heart. Actually, heart is working, but its performance is very low flow rate. And they need to maintain the blood flow using devices outside of the body. And this is the connection point, one of the connection points. This cannula is inserted into the artery. But for example, is there a difference between inserting the cannula into subclavian artery, which sends blood into arms, or to the pulmonary arteries, which sends blood into lungs? Because it is for surgeons, there is no difference. Whichever is easier for them, they perform it on the patient. Because these are mostly pediatric patients, and their cardiovascular system is very tiny, small, and it's not easy to access every location easily. So whichever easier, they choose that one. But we have performed a study if there is really a difference or not, and this is the result. If you insert the cannula into the subclavian artery, arms, the arteries going to the arms, and we see this result. And if you insert into the lungs, lung artery, pulmonary artery, we see those results. This one. And this is the arteries, they're called neck arteries. They are perfusing blood into brain, cerebral arteries. And if we look closely, we can see the difference. The difference is major. There's an obvious difference. First of all, the flow is not symmetric in this one, for this scenario. But for this one, it's symmetric, as expected, actually, and wanted. Also, there's a backflow, and you can see the backflow in the left artery, again going to the brain. So we have shown that actually the location of the cannula matters, and all of these results has been published in biomedical journals mostly, and we are also doing all these studies with surgeons because actually they are finding us the problem. We are not finding the problem. When we find the problem, actually it is a bit artificial, and the surgeons don't like it, so they prefer their own problems. This is how we work with the surgeons. Actually, this one is how we work with surgeons. We first get MRI or CT data so we can reconstruct the 3D geometry of the patient-specific cardiovascular system. And then perform virtual surgery, possible scenarios. These are all done by surgeons. They decide which type of surgery they want to do. And we simulate all possible scenarios, sometimes 10 scenarios, sometimes 5, sometimes 15 scenarios, and find the, let's say, best possible scenario and share it with the surgeon. After that, surgeon decides which surgery they want to perform, because sometimes it's not always possible to perform that specific surgery on that specific patient due to some anatomical difficulties. And yeah, sometimes we 3D print them so that they can practice beforehand the surgery. Optimization process is it's a bit complicated process because, for example, one of the criteria is the blood flow going to the lungs. What is the flow rate going to the lungs, for example, after the surgery? That's one criteria, but it's not enough because these are mostly pediatric patients. You need to also optimize the flow going to the brain. You need to optimize, otherwise the growth of the brain will be slower, and it's an irreversible process. There's no going back. So there will be neural deficiencies in the baby. So we are checking blood flow in the cerebral arteries, brain arteries, lungs, and if possible, renal arteries going to the liver or kidney, the fatal organs, the most important major organs. That is one aspect of the study. But there are other aspects because, for example, in this one, this is a shunt surgery. They are the surgeons connecting, diverting, changing the flow direction in the cardiovascular system so that, for example, these babies are born with a lack of pulmonary arteries. So there is no blood going into the lungs, right? So they need to do these types of shunt surgeries. I mean, it's a kind of, let's say, graft pipe connecting two other vessels. And after the surgery, if they don't like the outcome, for example, they repeat these surgeries, and the repeat rate is very high for these surgeries. So the success rate is very low, actually. And another aspect of the study is the pattern of the graft, actually. Because after the surgery, the graft closes easily due to, let's say, abnormal flow and a graft which is not natural, right? If it's natural, then the patency will be higher, actually. But these grafts are not natural, and there's a abnormal flow. Let's call them abnormal flow. The patency of the graft is lower than expected. So, for example, if it is closed after 6 months or 1 year, the surgery is repeated with another graft. So we are trying to optimize the patency of the graft too. And in the literature, I mean, it's going back to 1950s, it is mostly correlated with wall shear stress. We are trying to check and find the best scenario for the patency of the graft based on wall shear stress distribution. Sometimes it is lower wall shear stress, sometimes it's higher wall shear stress, sometimes gradient of the wall shear stress or oscillatory wall shear stress. We are trying to predict the patency based on those mechanical parameters. Another optimization aspect is turbulence. We are all familiar with. Because if there's a turbulence and vorticity in the blood flow, as we can see here, we can see the vorticity here and some locations here. It is actually bad because it will cause energy loss, right? Pressure drop. So there will be higher load on the heart, which is also not wanted. So there are lots of actually aspects for the optimization, There are some other aspects. And based on those parameters, this is actually optimization problem. We try to find the best possible scenarios, patient specifically. And sometimes it is not always possible to obtain MRI or CT. The previous data was from a real patient, which was maybe 3 days old. Sometimes it's not always possible to get MRI or CT of the patient due to some clinical difficulties. So we have some templates which represent the diseased or healthy cases of the patients. We have generated these geometries on SolidWorks, for example, and 3D CAD software. So we can modify these geometries based on the anatomy of the patient and the required surgery and do the simulation. And sometimes, for example, we have the template of the lower body but the real patient data for the upper body, whichever is available. And try to predict the hemodynamical, mechanical parameters. For example, in this one, this is a circle of Willis in the cerebral artery. We are predicting the flow rate. It should be symmetric as much as possible, and the wall shear stress distribution should also be should have a smooth gradient. That is the optimization we do. Another study is about connecting superior vena cava and inferior vena cava. This is a Fontan surgery. We have graft here. This one is the graft. I think you cannot see. Yeah, this one is the graft, and this is inferior vena cava and superior vena cava, and they are actually the main veins. They are toplar damar in the body, and when the surgeons do this surgery, they try to connect two vessels with using this graft, because this is a single ventricle patient. So actually, one of the ventricle is not functioning. This patient has only single ventricle. Normally, healthy people have 2 ventricles, but one of them is not functioning. So instead of sending blood into the ventricle here, they bypass the ventricle and they directly send the let's call blue blood, dirty blood, into the pulmonary arteries for the oxygenation process. But the problem here is the graft anastomosis location and configuration matters, because if the flow is abnormal in those grafts, there will be higher load on the heart. That's one problem. Another problem is again the patency of the graft. For example, if you do a connection like this, you will have vorticities as shown here, and it will be an extra load on the heart. That's one problem. And if the wall shear stress gradient is very high in the graft, then the graft will be blocked sooner than expected. Then you will need to do the surgery again. So to check what kind of flow you get during the configuration, for several configurations of these grafts, we have done an experimental and computational study. This is a straight connection. This one is straight connection, and this one has an offset. in one direction, and this has a twist. And after having those configurations, we have pressurized these grafts so that they will have exactly the same physiological pressure inside, like the blood flow is ongoing. After that, I mean, we have the geometry, physiological geometry, and we did 3D scanning so that we can get the exact shape of the grafts while functioning, while heart is pumping. And then, after having those physiological geometries, we performed simulation. This is a blood flow, computational fluid dynamics analysis. What kind of pressure drop we'll get after performing several different configurations. One is straight, one has twist, one has offset. And as you can see here, for example, the offset, if there is zero offset, and you will have and let's call it 100 pressure drop. And if the offset is 0.5, then you will have 20% higher pressure drop. Pressure drop means energy loss, and it is higher load on the heart. And this is not one time, actually. This is, for example, maybe 1 billion beats for a whole life cycle. And if the offset is 1 diameter, then as you can see, the pressure drop is threefold, 3 times higher, two times higher than the straight configuration. And actually, the surgeons don't care much about these issues, although they know there are problems. There are patents problems in those grafts. They don't care about the offset distance. I mean 0.5 or 1. It doesn't look like it will make a huge difference as shown here. Also, we have tested several different grafts because, for example, the porcine or bovine obtained from cow or pig natural tissues has lower patencies. They are known with lower patencies after the surgery. But the problem is they have higher pressure drops. They cause higher pressure drops because you cannot control mechanical properties of natural tissues while you can control mechanical properties of artificial tissues. And as you can see, the porcine has 6 times higher than artificial grafts, the pressure drop. Yeah, that was another study. And another study we did perform is coronary artery bypass. All previous surgeries were performed on babies, newborns. They were congenital diseases. This one is adult disease actually, and this is the most common surgery performed in the world still, coronary artery bypass. And the problem with the coronary artery bypass is when you do the bypass operation, you need to do mostly more than one stenosis repair process because there is not always only one stenosis. Mostly there are more than one stenosis, sometimes 3, sometimes 5. So, for example, if they don't prefer bypass operation, they do stenting. They place, for example, 5 stents in a patient. But if they will do bypass operation, they need to optimize the locations of the anastomosis and the configuration of the anastomosis. Because you don't have infinite freedom. You have lots of restrictions while doing the surgery. And sometimes, for example, you have some freedom, degree of freedom, you can decide, but you don't know how to decide it. I mean, the surgeons don't know how to decide it. For example, in this one, this one is called Lima connection. It is a diverging artificial artery from the neck arteries, and it's connected anastomosed to the converged to the coronary arteries. But for example, what will be the connection angle? That's one question. And what will be the distance of the anastomosis after the stenosis? For example, you can do the anastomosis just after the stenosis, or for example 2 centimeters after the stenosis. Which one will you prefer? Surgeons mostly prefer to make the distance as low as possible. But in the study we have shown that actually that is a big problem. That is actually, and they were complaining about the restenosis. After the surgery, for example, 1 year after the surgery, they will see other stenosis at the same places. And we have shown that actually this anastomosis just after the stenosis causes very high wall shear stress gradient at those regions, and it is highly correlated with stenosis formation, plaque formation. And in this study we have suggested to make the distance as much as possible, but of course you don't have infinite freedom there either, because you have to make the connection artery, and the connected artery has somehow similar diameters. But still you have, for example, 1 or 2 centimeters space for leaving a space between stenosis and anastomosis location. Also there are other issues, for example, what kind of serial or parallel connections, what kind of connections you will do. That's another question. Also, the angle of the connection, does it matter or not? And yeah, we have shown that the angle has minor effect actually in this one. But of course, these are patient-specific studies. These are patient-specific geometry reconstructed from MRI, and we have to repeat all these. I mean, maybe we don't have to repeat, but to optimize the best performance for the specific patient, we have to do all these simulations for that specific patient. Otherwise, we can have some general comments, but for example, about the serial or parallel connection, we cannot say anything for that specific patient. We can say something about the location, space between stenosis and anastomosis, but not for all parameters. So they should be repeated. This is a heart pump, and actually the most important parameter for designing a heart pump is the blood damage, actually, how much damage you have. And these are, heart materials. They are not soft, right? They are artificial hearts, and you need to be sure that you have optimized blood damage performance. Because when you design a heart pump, that's the most important part actually. So this is a study about, we are trying to optimize the geometry and the flow parameters. For example, should it be pulsatile? Should it be steady flow? Should we For example, what kind of turbulence you will get and what kind of energy consumption you require for the maintenance of the pump. This is actually most of the surgeries here for pediatric patients are temporary surgeries. For example, the first surgery is aortic arch repairment. Second one is shunt anastomosis. And mostly, sometimes these surgeries are enough for the patient and they live until their end of life with those surgeries. But most of them, those surgeries are not enough. They require additional surgeries. For example, some of the patients I have seen patients who have been performed 20 cardiovascular surgeries until the age of 20. And after that process, mostly their heart fails, collapses, and they require artificial heart transplantation. And also it is not, unfortunately, the final process because of the blood damage actually. The quality of the flow is never good enough for these patients so that they can live, for example, 60 or 70 years more. So eventually they need heart transplantation. All these processes are mostly temporary surgeries, but the reason for this is the flow profile is abnormal and you cause lots of blood damage. That's the reason. If you can optimize these design criteria, then maybe hopefully those patients will not require heart transplantation eventually. Those studies were mostly about fluid dynamics analysis, and we have done some tissue mechanics analysis too. These are mostly, we are trying to optimize here the deformation of the vessels, so I called tissue mechanics. Actually, there are fluid dynamics analysis tool here. This is the actual size of a newborn heart. This one, the size of a thumb. And these green vessels are the repairments. And you can see it, actually they are very tiny. It's like doing those surgeries is like art. And since there are lots of parameters you need to think about before the surgery, it is really almost impossible to optimize without doing any simulation or analysis. And actually that's how they do it now still. Unfortunately, because lack of enough engineering support. In this study, the patient undergoes pulmonary patch surgery. In this one, the patch of the pulmonary artery is stenosed. It's narrow, tiny. The diameter is very low, so that the blood flow going to the lungs is very low, lower than expected. So you need to enlarge that region, right? So the patient will have normal blood flow rate. That is the reason for the surgery. But the problem there is you are repairing one of the major arteries. And the heart is pumping, right? While the heart is pumping, you cannot do the surgery. So what they do is stop the heart and remove it from the body. Of course, the blood flow is kept running using devices outside of the body, artificial pumps. But the flow in the region where the surgery is performed is bypassed. There is no flow in the pulmonary vessel. So the problem here is when they do the surgery and close the chest, this is open chest surgery, and when they check the performance of the surgery, they see that, for example, the stitches are sometimes too tight because they stop the heart, there is no pressure inside, and when they start the heart, there is pressure inside. And they see that the stitches are too tight, so that there will be extra stress on the vessel and the tissue, artificial tissue, then probably they will need to repeat the surgery within 1 to 2 years. Or, for example, if they do a very loose stitch, then there will be blood leakage after the pressurizing when the heart starts beating. So that is the problem here, actually. And our solution to that is we are doing, again, a virtual pulmonary artery repair surgery. Like it is, like the heart is still beating. This video shows better, I guess. Yeah, we have the geometry, stenosis geometry, right? Blocked. The blood is blocked. And then we do a virtual slit, open it like they do it in surgery, and we do all of this while heart is pumping, beating. We have the opening space, and we find the exact geometry of the patch while like the heart is pumping. So the surgeon, what they do here is they get the exact shape before the surgery, but in the normal surgery they do it during the surgery. And they have a sheet like this, for example, and they have scissors and cut the shape, and they do the stitching during the surgery. But here, in our solution, they can do it beforehand, and they will have the exact shape, 3D shape. But unfortunately, they cannot implant it yet because 3D printer is not printing an implantable material yet. But they will have the exact 3D shape, and they can cut it from their material, 2D planar material, and place it in the surgery, place it in the pulmonary artery of the patient. This is, of course, there are other parameters because there's a blood flow too, right? We need to optimize the blood flow too. Again, in terms of pressure drop, turbulence, and stress distribution. Those are also criteria. And in this one, we have seen actually many interesting results. For example, the size of the slit. It's a parameter, right, for the surgery. And our studies show that it should be at the exact shape of stenosis region. It shouldn't be longer or shorter than the stenosis region. That's one of the outcome of this study. Also, for example, should you do oblique or straight slit? Straight is better, we have found that. Also, we have suggested another solution with 2 slits, one at the upper side and one at the lower side. Then because you will have an exact cylindrical shape. Otherwise, you will have a bump like this in this one. But the 2 slits, surgeons didn't like the 2 slit scenario because they said there's not enough tissue to hold the patch there then. But this is a usable solution, and we have patented this. This has a patent for this kinds of surgeries, and also it can be a solution for any type of surgery which is performed while the heart is stopped. Yeah, I mean, it was for a cylindrical shape, but we can repeat the surgeries for any arbitrary geometry. This is a study about non-invasive material property derivation. One of the most difficult thing is, to get the material properties of patients, because you are doing patient-specific simulation, right? But if you cannot obtain the patient-specific material properties, then you will lose some data, some information. So we have suggested a solution for this based on the pressure measurement, the cuff pressure, right? The cuff pressure. Based on the dynamic cuff pressure and the diameter change, which can be obtained using MRI or echo data. We have the change of diameter in time plus change of pressure in time. So we can have a inflation test, actually. Not exactly the same, an experimental one, but it's like an, let's say, similar to inflation test. We have some, we can obtain some data there, and we can fit it into some experimental material model so that we can use it in our simulations. Another, we have fitted it to, we have generated some data and fitted to experimental tests. We have validated the results. And also, one of the advantages here is we can also get residual stress, actually, because natural tissues has residual stresses, which, for example, mostly the artificial materials don't have residual stress, but natural tissues have residual stress, which should be incorporated into the simulation. By using this model, we can also predict the residual stress. The most important part of this novelty is about the non-invasive part, actually. Otherwise, material measurement is highly available. This study is about a buckling study. We have a collaboration from New Zealand, a surgeon from New Zealand. They had a problem of buckling of testicular artery, but this is a rotational buckling. It is common in males after some age, and the solution is open surgery, which is nobody wants nowadays. Another solution from this group is stimulating some points by electricity on the body so that there will be higher pressure inside the vessel, right? And it will open the buckling. It will reverse the buckling process by twisting in the inverse direction. So they won't need any open surgery. But the problem here is how much stimulation you need or how much pressure you need, because if you don't have enough pressure, then you cannot solve the buckling. But it's a rotational buckling. But if you have too much pressure, very high pressure, then it will buckle in this direction. Instead of rotational buckling, it will be longitudinal buckling. That's also another problem. So we have done some studies on this, some experimental and computational studies to optimize the pressure inside the vessel and the angle of buckling, because how much buckling you have there, rotational twist during the blocking process is related with the pressure you need during the surgery. Not surgery, this is treatment, because this is not a surgery. This is like a process like acupuncture, just touching some parts of the body and diverting the flow in that region and increasing the pressure. Some of these studies are performed like in some research medical centers, but they are not common yet because classical, traditional, conventional procedures are more widely used still because of lack of engineering support to these medical centers. Another study we are still working on, actually, this one. This is the embryonic aortic arch during the morphogenesis. Here the problem, these are congenital diseases, pediatric patient diseases, right? It comes after the birth. It comes with the birth. The question here is, can we prevent the disease before the birth? While the baby is in their mother body. But this is still an ongoing study. It's really difficult because it's a really complicated system. The cardiovascular system of the mother and the cardiovascular system of the baby is connected. And when you touch one of them, and all of them are affected, and there are some trials, but it's still in early phases yet. In this one, we have shown that some of the material deposition can be correlated with the fluid dynamics and the stress distribution caused by the fluid dynamics. But it's an early phase yet. Those were the published studies, actually, and nowadays I am working on these studies. We are trying to correlate the pulmonary arterial hypertension disease by using non-invasive techniques. For example, this one is a healthy heart. This one is a heart with a pulmonary arterial hypertension. You see this part is thicker. You see the wall of the heart is thicker than the normal heart, and also the pulmonary artery region is narrower. To diagnose the disease, they use some blood levels plus MRI, CT, and right heart catheterization. Right heart catheterization is they insert a catheter from your leg up to your heart so that they can measure the pressure and velocity in your heart and pulmonary artery, so that they will know if you have pulmonary arterial hypertension or not. But the problem here is this is an invasive process. It is a bit risky and expensive, and no patient wants to go under these measurements. And our solution to that was maybe we can correlate some, for example, hemodynamical parameters or stress distribution with the pulmonary hypertension. Maybe we can classify the disease level and the healthy subjects based on these parameters. Initially, we have done a normal heart, normal patient study on the right one. This one is a normal, healthy subject, and this one is a pulmonary hypertension patient. And we have shown that actually there's a major difference between those two subjects. We used only MRI data for this study, and so we didn't use catheterization. But the problem here is this is only 2 patients, so we needed to increase the number of patients. For example, we should have at least maybe 30-40 patients. So we have increased the number of patients and performed this correlation study. in this one, for example, the pulmonary vascular resistance, which is obtained by right heart catheterization, and the wall shear stress distribution, spatially averaged wall shear stress distribution, using MRI data. Also, the pulmonary compliance, which is again obtained by right heart catheterization, and the blood damage index, R index, obtained with CFD simulation. And we have shown that, for example, this has 68% correlation, this one has 84% correlation if we do one-to-one correlations. This is the framework, I mean the outline of the study for pulmonary arterial hypertension classification. We have CT scan reconstruction, preprocessing, meshing, and CFT and finite element simulations, and then we compare with clinical measurements. I'll be quicker because we don't have much time. But another problem with that was we were doing one-to-one correlations, and the correlations was between 68 and 84%. So we checked if we can do multivariate analysis. I mean, for example, instead of only spatial average wall shear stress, we can get wall shear stress plus blood damage index versus all clinical parameters. That was this is a canonical analysis, correlation analysis study. And we have shown that this was done with 34 patients, pulmonary arterial hypertension patients. The correlation is 91%, is much higher. Another study we are performing is predicting the rupture risk of cerebral aneurysms. This is a big issue. Actually, this is I think, number 2 cause of death still in the world, rupture of cerebral aneurysms. It causes either stroke or death. It's very common. But the problem here is sometimes it is aneurysms are at very risky regions, so that you need to be very careful. Maybe while repairing this disease, this aneurysm, you can cause higher risks actually, stroke or death, by causing rupture in the aneurysm. So nowadays it is also a very hot topic that which aneurysm will rupture and which will not rupture, which is risky and which is not risky. That is a question, open question, still investigated. And we are also working on it. For example, this one, first of all, to predict, to do simulation on the aneurysm, we need to do segmentation, right? And we have performed segmentation, for example, here maybe 25 people. 25 different people have done segmentations, you see here. And we have shown actually that this segmentation is highly correlated with the person. I mean, whoever does the segmentation influences the results, changes the results. That's one of the results we have published. And for example, in this one, cerebral, there are 5 cerebral aneurysms, 5 like balloons. We can imagine it like balloons, and obtained from MRI, CT data. And you can see the differences in the segmentations. The segmentations have been done with different people, and you have different results. Actually, this is one of the biggest problems to model these cerebral aneurysms, the inaccuracy of the segmentation. We have shown that. And also, due to that segmentation inaccuracies, CFT results are also sometimes highly inaccurate due to segmentation differences. as you can see here. But I mean, the suggestion was for solving these inaccuracies was having a radiologist to do those segmentations. But it is really expensive process, and for example, these segmentations are done, for example, between 1 hour to 1 week. One group made the segmentation in, let's say, 3 hours, and one group completed all segmentation in 1 week using the help with radiologists. And that's, I mean, if you want to, for example, hundreds of segmentations for hundreds of patients, then you will need hundreds of weeks. That's not very acceptable. So our solution to this was to reduce the inaccuracy. We suggested normalization. For example, if you have the values in this part, you can normalize it by using the neck of the same segmentation. Then the inaccuracy is much lower than the absolute values. We have shown this. We didn't publish it yet. We have submitted this study. But, I mean, it is a good alternative to do the segmentation in 1 week. It will be accurate, but we don't have 1 week. Otherwise, the process will be very expensive. We are trying to make it available very commonly. Another study we are working on is creating a template. For example, if you have a template, healthy template, for example, you have a template obtained from 100 healthy people, then you can find the differences between disease geometry and the healthy template. That is our study about it. We are trying to get healthy patients' data now so that we'll have a template. This is an ongoing process still. The other study we have completed is an experimental study. This is the flow loop. We have a phantom here, which is 3D printed using an MRI of a patient with abdominal aortic aneurysm. Here we are trying to characterize the aneurysm, abdominal aortic aneurysm, using only MRI. And this is the validation test. We have phantom here. We have some resistances, capacitances, and the pump for pulsatile flow. That is a video showing the flow loop. Yeah, this is the phantom. And this is the pump for pulsatile flow. It generates pulsatile flow. And it has resistances and compliances to represent the deformable vessel. And the resistances are for example, to represent the rest of the body, because you don't have all organs here, right? You have only a limited part of the organ. Abdominal aortic aneurysm part you have, but you don't have, for example, the liver or kidney or the lungs. So to represent them, we use resistances. And we have verified our results. I mean, these are the measured values we have obtained from our test, and also we have compared it with the literature so that we know our flow loop works accurately. Then, to get the deformation and the velocity distribution, we have performed an MRI scan on this system. It was difficult to do that because of the properties that you can use in the flow loop, because they should be resistive to MRI study. So we have performed all this flow loop circle while the pump is sending flow into the aneurysm region, and then we obtained the flow rate, flow distribution, 3D flow distribution, and the deformation, so that we can characterize the deformation and the flow. The final, actually, aim of the study is trying to get a quick alternative way of characterizing the aneurysm. Characterizing means the risk of rupture and type of treatment you will decide. Without doing finite element analysis, CFT analysis, and without using material properties. That was the reason, aim of this study. We have used the membrane code to replace all those finite element analysis, so that we will not use material properties. It is, we have the pressure inside the aneurysm domain, and we have the exact geometry. Then we can find the stress distribution actually, without knowing the material properties based on the equilibrium of force on that specific geometry. And we have shown that we can replace finite element analysis with membrane analysis code, with a difference or with an error of 10%. So, I mean, after that, we can get, do the MRI scan, and without material properties, deriving material properties of the patient, and doing finite element analysis, we can use membrane code. For example, finite element analysis takes, let's say, 17 hours for this specific case, because you have maybe 2 million elements, plus you have the thickness change of the body. But our membrane code solves the same problem in 3 minutes. A drug delivery, actually the first solution to aneurysm is surgery. But nowadays, there's another solution developing, and we are trying to do a study on it. We have some projects on it. It is a drug delivery to the aneurysm, so that to see if we can reverse the aneurysm formation, right? In this one, there's a plug here. Can we reverse this process so that the tissue will be healthy again? That's the question. And actually, nowadays, there's a drug called PGG. Its name is pantagallol glucose. It is highly available in pineapple, for example. I mean, it's a natural drug that is said that it can reverse this process, and you can obtain healthier tissues than the aneurysm one using this drug. But the problem with the drug is how will you deliver? Yeah, we have done some experimental tests. This is a healthy tissue, mice tissue, aorta, abdominal aorta. And this one is the diseased one with abdominal aortic aneurysm. This is healthy, this is diseased, and this is treated with the PGG in one session. In one session, we have about 15 to 20% reverse. We have gained the mechanical properties of the tissue. Actually, this is a very important finding. I think it will be available within 5 to 10 years in all clinical centers instead of doing the surgery. But the problem here is delivering the drug into that region, because if you don't have a device, or if you use only a cannula, you can deliver the drug there, but the blood will wash out it, right? It sweep it. The drug will not stay there for a long time. That's the biggest problem. What you can do is totally clipping the vessel, right, and deliver the drug. But in that case, you have limited time, plus clipping the aorta will block blood flow into the legs. And there are some cases which cause paralyzation. There are paralyzed patients due to that long time of clipping. Our solution to that was a device like this, a funnel like this, and without blocking the flow, I mean blood flow will go in this direction into the legs. We can deliver drug here because there's no flow using a cannula. That was our solution. This is an ongoing process still. And we did a simulation while we have an aneurysm and a funnel inside the aorta. But you can see that actually this is a jet flow, and it is causing backflow here, and this will wash out some of the drug, and also this jet flow is not normal, it's unhealthy. It can cause some abnormal blood flow and blood damage, which is not wanted. So this was the first solution. And to make it steady, we have designed a shape like umbrella-like mechanism, so that it will stay steady at the aorta. It will not move with the flow rate. That was the first solution. And the second solution is this one. In this one, we have almost exactly the shape of the aneurysm. And there will be a normal blood flow through this device. And the drug delivery will be made using those tiny holes. There are holes here, and the drug will be delivered in those regions using a syringe. Of course, the cardiologist will do those operations using a cannula, inserting a cannula and delivering the drug. Of course, this will be a tiny one. I mean, it will be a narrow device while inserted into the body from the leg artery, but it will be inflated after it's inserted into the body. We have also patented this study because this is a device, so you can easily patent it. You cannot patent all the medical solutions. For example, you cannot patent a special type of surgery type, but you can patent the devices like this. Another study we are doing is microchip design. In this one, we are trying to characterize coagulation properties of the blood, because the methods used to measure the viscosity and the coagulation properties, they are not very accurate. So we have developed this microchip to see if we can measure the properties accurately. Yeah, these are the pillars, and this is an experimental and both computational study. Yeah, you can see these are the pillars. And when there's a blood flow, and whether it's coagulated or not, what kind of flow you will have, and what kind of deformation on the pillar you will have. This is an FSI study. So we have the flow and the deformation on the pillar to characterize the viscosity and the coagulation, which is normally difficult to track. Okay. This one is an oxygenation study. We have the elongation index for the cells obtained experimentally in an ideal case, but in the microvessels, what kind of oxygenation or deoxygenation properties you will have is an open question. So we simulated the distribution of elongation index and its relation with oxygenation using fluid dynamics. And this is the oxygenated blood, this is the deoxygenated blood, and these are the regions with high elongation compared to this region. I mean, the elongation, if the cell is highly elongated, then it will lose its capacity to carry oxygen. That's what we are trying to show here. And all the studies here are performed on mostly clusters, because most of the studies takes too much time. But to check the speed up and efficiency of our parallel methodology, we have done some studies. For example, if you have let's say this one, if you have a matrix of 32 million by 32 million, then you will have this orange-like, I think, color line. For example, up to, let's say, 2500 cores, you will have a good speed up and efficiency. But after that, the efficiency is very low. You have a very low increase in the speed up, but the efficiency is very low, so the cost will be very high. But for example, if you have a 64 million by 64 million, then maybe up to even 15,000 cores, you can go and you can gain some speed up without losing efficiency a lot. I mean, we have done this study because sometimes you pay for the CPU time you use, and if you have very low efficiency, actually you will lose money. It means you will lose money. If you use 5,000 cores instead of 2,500, then you will lose lots of money without gaining any speed up. That's what we try to show here. We have done these tests up to 32,000 cores and checked the speed up of our solver. We have also done some tests using CUDA, GPU computing, but the GPU computing efficiency is not very good compared to CPU only, but this is for CFD results, of course, only. But the thing here is, even if you use the same number of cores, you will get almost the same result, same speed up, but the thing here is GPU is cheaper, so still you can use it. Yes?
And what kind of environment are you using for solutions? Is this
Some of them
Are
are
in-house.
in-house, some of them are commercial, some of them open source. We have some in-house codes. Also, we use OpenFOAM, we use Fluent, and we use FEBio. I mean, many things. It depends on the problem actually, because not all the solvers has all the capabilities, although they say they have.
In your vessel simulations, like you shown various analyses, including FSI, and are you using these, I mean, mostly in commercial or?
If it is only CFD, then we use in-house code or open source code. If it is FSI, we use Fluent, ANSYS Fluent, or other, for example, Fluent plus Abacus. The reason for that is there is not a open source FSI software available which is validated by a third party. I mean, which has some third party publications. We couldn't find it. So, and we didn't want to be that third party because it's time consuming. So we kept going with Fluent plus Abacus instead of validating some other group's software. Because it's an expensive process. We don't want to do that. And it has not been done, unfortunately. Although there are many softwares that claim they have that capabilities, but they don't have. No problem. And I think that's all. Thank you very much for listening and for your patience. If you have any questions, I can answer.
In your early slides, you showed simulations, and in those simulations, how do you treat these simulations? Like, are they time dependent, or how do you apply blood material? Is it non-Newtonian or?
It depends on the problem again. For example, if it is a abdominal aortic aneurysm, it's a large artery. You don't have to use non-Newtonian model. But if it is a microvessel, yeah, you need to use a non-Newtonian model. Then we use non-Newtonian. But if it is not necessary, we don't use it. And for example, if you require pulse style flow, and if we have the pulse style data, then we use it. But if sometimes we don't have the pulse style data, then we fit it into some previous data we have obtained from other patients, unfortunately, because it's not always available, the pulse data.
Can I ask you, you said these simulations take a lot of time.
Yeah.
And you want to reduce time like significantly.
Yeah.
Did you consider applying a study including some machine learning code maybe to, because the geometries are quite similar from patient to patient in my opinion. Like the vessels are similar but slightly different from each other from patient to patient. So maybe.
You mean this, for example, this one.
Like maybe if you, before making these simulations for patients, you can generate a series of simulations, and using these results and these geometrical parameters, you can devise maybe some correlation.
Actually, this is where it is going, probably. I mean, in the maybe next 5 years, it will go there. We'll have the geometry, and we'll have previous simulation results, and we'll try to fit it. But we are not yet there, because the simulation results vary a lot between different geometries. We need to have many more variety of geometries and simulation results. Also, another thing is the boundary conditions differ a lot. That's another issue. But maybe, yeah, ultimately it will go there, but we have lots of way. First of all, for example, the segmentation is by itself is a big issue. There is still no available methodology to do full automatic segmentation, unfortunately. That's the biggest bottleneck now. After that, maybe we'll go there. No problem.
Şenol Hocamıza çok teşekkür ediyoruz.
Ben
Aramızda
teşekkür
bulunduğu
ederim.
için.
Sağ olun.
Güzel soru
Geldiğiniz için, sabrınız için de biraz uzun oldu. Kusura bakmayın.